So how are tumor treating fields delivered for glioblastoma? There is a portable device. It is non-invasive. It localizes the treatments to the operative bed, to the areas at risk. The overall intensity is typically 1 to 3 volts per centimeter. The frequency for glioblastoma is 200 kilohertz, and it's alternated in 2 different directions. The arrays are applied to the scalp, so the scalp is maintained shaved in order to allow the arrays to adhere to the scalp. And the positioning of the arrays is highly individualized based on the 3-dimensional internal anatomy, based on an MRI that is submitted after radiation for determination of array placement. So I'm just going to introduce a rather interesting case, not a typical glioblastoma case. 71-year-old woman who actually had a prior diagnosis of a grade 2 meningioma of the right sphenoid wing. In itself, a challenging problem. And she was undergoing routine surveillance MRI when she was noted to have T2 flare hyperintensity in the left middle frontal gyrus involving the motor cortex on tractography. She was essentially asymptomatic from this finding. She underwent a left-sided awake craniotomy and a subtotal resection since there was a lot of flare abnormality that was ultimately discovered. And the pathology came back as glioblastoma, IDH wild type, MGMT methylated, EGFR amplified, TERT promoter mutated. She was dispositioned to receive standard chemoradiation to 60 gray with concurrent temozolomide, followed by adjuvant temozolomide with tumor treating fields. So as I mentioned, tumor treating fields are personalized through individual treatment mapping. And so there is a software, Novital, which can be done within the clinic or done by the Novacure, which produces these arrays. Based on the MRI, the software generates a layout for how the arrays are placed on the scalp to maximize TT field intensity and really utilizing the MRI images to their fullest. Data for the use of TT fields in the treatment of newly diagnosed glioblastoma, really level 1 data comes from this trial, the EF14 trial, also known as the other Stoop trial. This is the scheme. Patients were given standard chemoradiation, and like our patient, could be randomized to either getting tumor treating fields with adjuvant temozolomide or adjuvant temozolomide alone. The tumor treating field went on until either second progression or 24 months. The adjuvant temozolomide was a standard 6-month cycles. This is the intent to treat population analysis from the EF14 trial. As you can see, there was a significant survival benefit for those receiving adjuvant tumor treating fields with temozolomide. The survival at 2 years for temozolomide alone was 31% versus 43% for the combination therapy. And interestingly, as you go all the way out to 5 years, you see more than a doubling in survivorship of 13% compared to 5% for the single treatment. The median numbers are 20.9 months for the combined therapy versus 16 months for the temozolomide alone. This led to approval of the treatment for newly diagnosed glioblastoma. What's also interesting is that in subgroup analyses, the use of tumor treating fields was independent of all the prognostic factors. So regardless of the prognostic factor, there was benefit to adding tumor treating fields to adjuvant temozolomide in all cases, regardless of age, regardless of MGMT status, regardless of extent of resection, regardless of performance status. This led the NCCN to include the use of tumor treating fields as level 1 evidence in guidelines for methylated and unmethylated newly diagnosed glioblastoma for age less than 70 and for age greater than 70. So in all cases, this was recommended as a treatment. What was also interesting from that trial was that quality of life was maintained over the 12 months studied. There was no decrement in quality of life with the use of tumor treating fields, perhaps some mild increase, but overall sustained. And so this is important, particularly the patient-reported, because many had concerns that this would be an added burden to patients, having to wear the arrays, having to wear them 18 hours a day, where they wear them all day, but having them connected 18 hours a day, the constant skin care, the constant shaving of the head, and nevertheless, patient-reported outcomes and patient-reported quality of life remain the same as those receiving temozolomide alone. The survival benefit seemed to be correlated to the increase in the use of tumor treating fields. So the longer you used it, the more the survival benefit. At some point, at least in the EF14 trial, there was only a minimal gain. It became statistically no longer significant when you were at about 50% of the recommended time. But nevertheless, more was better, and patients know this, and some patients choose to wear it essentially nearly 24 hours a day. And a really interesting study by Matt Ballo and colleagues that was published 2 years ago started to look at the dosimetry. You know, as radiation oncologists, we really want to know what is the dose coming to the tumor bed, to the areas at risk. And looking at the local minimal field intensity and the local minimal power density, if those could be higher, so the field density greater than 1 volt per centimeter, the power density greater than 1.1 milliwatts per centimeter cubed, both of these showed a significant survival advantage, really suggesting that the dosimetry is a key component. And indeed, there is a revised version of the treatment planning currently in beta testing to attempt to improve the dosimetry of tumor treating fields in the brain. Okay, so let's do a follow-up question. Rethink your choice if you're not satisfied with your choice. If you're happy with your choice, that's okay. But for patients, again, for patients getting with glioblastoma being treated with tumor treating fields, which of the following factors would contribute to the greatest survival benefit? So I'm going to read through these, make sure there's no confusion. One is I don't know, in which case maybe I'm not doing a good job up here. 2, the device is set to high power density and worn 10 hours a day. 3, the device set to high power density worn for more than 18 hours a day. 4, high power intensity worn more than 12 hours. And 5, set for high power density and a frequency of 150 kilohertz, or 6, not applicable. So please give us your answer. Okay. Whoop. I think there we go. Thank you. Okay, so we're looking at the blue versus the green. The blue is the pre-test, and the green is the post-test. Number 3 is the device set to high power density and worn for more than 18 hours a day. And it's nice to see the increase from 59% to 82%. That is the correct answer for that question. And for those of you that were in the 3% that did not know, now you know. So that's excellent. Let's go on. So what's interesting in this study, also from Matt Ballo's group, and this was presented in abstract form a couple of years ago at this meeting, was that when you looked at the areas that regressed versus the areas that progressed, the field dose was higher in the regressed areas than the areas that progressed. And this is, again, encouraging evidence to suggest that there is truly a dose-response relationship between tumor-treating fields and tumor response. And this is exactly, of course, what we see with ionizing radiation, and really goes on to support this concept of tumor-treating fields being another form of radiation for radiation oncologists to deliver, but in this case, of course, a non-ionizing radiation. Okay, so I'm going to spend a few minutes now talking about some of the emerging trials that involve glioblastoma and tumor treating fields, or other tumors in the brain, particularly metastases. So we didn't go through the preclinical data with tumor treating fields and the immune reaction that it elicits, but there's quite a lot of elegant preclinical data to show that indeed treatment tumor treating fields activates the immune response. And therefore, there are two trials, interesting trials, single-arm phase 2. One is adjuvant temozolomide with tumor treating fields and pembrolizumab, a PD-1 inhibitor, and of course the other is tumor treating fields with nivolumab, another PD-1, with or without ipilimumab, and that of course is borrowing somewhat from the melanoma and other disease site literature where there's a benefit to combining ipi and nivo. Looking at other strategies in glioblastoma, the EF33 trial from Novocure is looking at high-density transducer arrays, so really focused on that dosimetry question and looking at it in the recurrent setting in a phase 2 trial. And because of the scalp irritation that we're going to talk about in a minute, there is a scalp-sparing version of radiation that combines temozolomide and tumor-treating fields, and we can see that abstract on Wednesday here at the annual meeting. And then in brain metastases, similarly, we're seeing that there's the ongoing phase 3 METIS trial of patients with non-small cell lung cancer bearing Mets after radiosurgery to try to reduce the distant brain Met failure rate. And then there are these phase 2 trials, again, building on the checkpoint inhibitor data from melanoma to combine tumor treating fields. And what's really interesting is looking at small cell because of the rather brain systemic distribution of Mets in small cell lung cancer. So these are some of the trials that are under investigation. One trial I will highlight is the ongoing Trident trial, or EF32 trial. This is a trial where building on the EF14 trial, where tumor treating fields are now added to the concurrent component of treatment. So patients are randomized to receive standard temozolomide with radiation followed by tumor treating fields and temozolomide adjuvantly, or adding tumor treating fields to the concurrent phase. And for those of you that may be enrolling patients in this trial, it is quite interesting that all patients do is unplug, and then they get radiated right through the arrays. There's a slight difference in the way you simulate the patient to account for the arrays, but otherwise it's a fairly straightforward treatment. And it also worth mentioning that, of course, tumor treating fields and temozolomide in the adjuvant phase are in both randomized groups because tumor treating fields in this context are standard of care. Okay, so one of the things we'll talk about is management of the dermatologic consequences. If there's any toxicity that came up from the EF14 trial, it was skin toxicity. And I think, I'll highlight more the middle column here, which is really a contact dermatitis from the adhesive that comes up from the arrays. And for this, the treatment is relatively straightforward. It's the use of topical corticosteroids. Sometimes you treat with antihistamines. In most situations, high dose or high percentage corticosteroids really do a great job of alleviating the contact dermatitis. Clearly, if you have a patient with hyperhidrosis, you have to do things to prevent the moisture under the arrays so the arrays adhere properly. And I had a patient that recently had a skin tag that they shaved off when they were shaving their scalp, and they ended up with a little trauma on their scalp. And what you want to do is, of course, you want that to heal, particularly if they're getting, say, on the Trident trial. So you just want to avoid maybe putting the arrays right on that until that heals. Always consult a dermatologist, and in your practice, it's wonderful if you have a go-to dermatologist that can be trained on the skin sequelae of tumor treating fields that you can use for your patients. So back to our patient, she indeed developed some contact dermatitis. She was given some a hydrocortisone was sufficient for her, 1% hydrocortisone, very low intensity on her skin. That was enough in her case to get rid of the contact dermatitis. What you also see here is her TT field usage. And she's an interesting case, so I wanted to highlight that, and we'll get to that in a second. So this is just use of topical corticosteroids, and you can see an example of this in the image. Sometimes it's itching, and of course you want the patient not to scratch. Usually the arrays prevent them from scratching, but when they change them, they may do that. They can develop a rash, and they can get quite concerned. So again, topical corticosteroids shift the arrays a little bit to try to alternate where the adhesive is sticking to the scalp. If things get worse, you can use moist compresses. And in the most severe cases, which are very, very rare, you can look at systemic steroid treatment. Of course, you may be using systemic steroids already in patients undergoing treatment. Okay, so follow-up question number 2. Based on the AE management recommendation, how would you now manage a patient with glioblastoma being treated with TT fields that has developed mild contact dermatitis? And again, number 1, I don't know. Number 2, high-dose systemic corticosteroids. Number 3, advise your patient to watch and wait. Number 4, advise your patient to change the transducer arrays less frequently. Number 5, prescribe a topical corticosteroid to be applied in the irritated area. Number 6, NA. So please key in your answer if you have not already. Okay, so again, very nice to see everybody went with number 5, and that's a 36% improvement in the answers, so well done, everyone. Okay, this is our patient, and I really wanted to highlight this because for the 6 months of adjuvant therapy when she was getting her adjuvant temozolomide, she was very compliant, a very motivated patient. And then she had some unrelated issues that forced her to take a big dip, and then she tried to go back up in compliance. She never really got back to where she needed to be. She had disease progression, so this was June 2019, and then in April 2021, she had definitive disease progression. She underwent in May a re-resection and then has now begun back on using the arrays. Still having an issue with compliance, but it is worth noting that more would probably be better, but she is 34 months from initial diagnosis, which is really outstanding. And if she continues with the arrays, she will hopefully, after the surgery, continue to do well. She is, of course, being re-challenged with temozolomide after this progression, as that is the indication to combine the two. Okay, so I'm just a quick take-home point in our last couple of minutes here. These are the sort of 5 principles of delivering good TT field therapy. First, the frequency is important. The normal cells have a very low frequency that they work with. The cancer cells are much higher frequencies, and there are frequency-specific, empirically determined frequencies for each malignancy that is treated. Intensity is important, so greater than 1 volt per centimeter, and so dosimetry is very important, or the power density of 1.1 milliwatts per centimeter cubed. And these are goals that may not yet be easily achieved with the current planning system, but something that will be available shortly. The longer the patient wears the device, perhaps the most important thing, the longer the exposure, the longer their survival. And compliance along with power density really is the best bet. So really getting the arrays on properly and wearing them as long as possible has the biggest survival impact. So before I close the first portion of this session, I just want to remind everyone again, we have these question cards. So if you have questions, please do write them down. For those of you remote, you can type your questions in, and we will answer those at the end of all 3 sessions. Great. Oh, we have some questions already coming in. So we'll collect these, and we will go through these and get to these at the end. Okay, so it's now my pleasure to introduce Dr. Kotecha, who is the Chief of Radiosurgery in the Department of Radiation Oncology and the Director of CNS Metastasis Program at the Miami Cancer Institute, a part of Baptist Health, South Florida. So I'll hand it over to you.
Thank you, Dr. Sulman. So I'm going to be discussing really implementing state-of-the-art multimodal strategies for malignant pleural mesothelioma and other thoracic cancers. We'll start off with a patient case. So this is a patient of mine, an 84-year-old gentleman with malignant pleural mesothelioma. It's actually the first patient that we treated with the device about 2 years now since its initial approval. He was medically inoperable, unresectable, had epithelioid histology, and disease predominantly in the left hemithorax, as you can see on these sequences from his PET-CT scan. So we'll come back to this, but essentially as we're thinking about the rationale for TT-Field's use in mesothelioma, a lot of the principles between the treatment of glioblastoma and our course in history and lack of really effective cancer therapeutics in that space really mimic or parallel our experience as well in mesothelioma, going decades without any new available systemic therapies. To date, there still remain limited treatment options available for this patient population, although we do have a recent introduction of immunotherapy into this space. And the chemotherapy response rates, which is what most patients are treated with in the rest of the world, are lower than what we experience with our other thoracic malignancies. Now, TT-Fields can achieve direct tumor kill. This is specific for mesothelioma cells, and we've seen this in vitro, the preclinical studies, both with cell clonogenicity as well as cell viability. And they may also allow for increased efficacy of chemotherapy. Again, this is something that's also been tested, especially with carboplatin, cisplatin, Pametrexa, the chemotherapies that we use for mesothelioma patients. Finally, mesothelioma is a relatively fast-growing tumor, and that may have more rapid tumor death from TT-Fields when the cells are attempting to divide. There are studies that show that mesothelioma cells are actually more sensitive to TT-Fields than glioblastoma. And again, we have the evidence now for glioblastoma, and so I'll show you what the clinical evidence we have now in the mesothelioma space. So now, transitioning from the brain to the lungs, now, TT-Fields are delivered using arrays of insulated transducers that are directly applied to the chest. This is similar in principle as Dr. Sulman mentioned for the brain. So here you can see in this layout the transducer arrays on basically a human anatomy sketch model. Now, these are laid out as cross arrays so that the front array on the right side is actually paired with the back array on the left side, and then vice versa. Now, if you're looking at the electric field distribution in the lungs, this is highest in the areas in the mesothelium. And as you can see, it's not uniform across the chest itself. The electric field distribution effectively covers the lung, and therefore it's useful in malignant pleural mesothelioma. And then we'll also transition to how it's used in the lung space as well. Now, as Dr. Sulman mentioned, the intensity of TT-Fields in the lungs crosses that threshold, that barrier of 1 to 4 volts per centimeter, which is above the minimum threshold that we need for a tumor response. That field distribution is also higher in the mesothelium than in the lung parenchyma itself. Now, we do personalize these TT-Fields layouts just like we think about for GBM patients, although unlike an MRI, this is done using CT scan to help facilitate the TT-Fields intensities to the anatomical region that we're actually treating. So now I'd like to go over the phase 2 stellar trial of TT-Fields and Pametrexa and platinum-based chemotherapy in malignant pleural mesothelioma, really what led to this approval. This was a study in 80 patients who had pathologic evidence of unresectable disease, had at least one measurable lesion, and had a good performance status. There are some key exclusion criteria, things that we think about in the clinic as well. You could not be a candidate for curative treatment, for example, with surgery. Patients could not have significant comorbidities as they needed to receive the chemotherapy as well. And they could not have any implanted electronic medical devices, something that we do see more frequently in the chest, for example, with pacemakers and defibrillators. These patients receive TT-Fields at 150 kilohertz, so that frequency is different for lung and for mesothelioma versus the brain, though they use the same threshold of 18 hours a day. The chemotherapy was Pametrexa and either cisplatin or carboplatin, and they received this every 3 weeks for up to 6 cycles. Similar to how we think about it for brain, the TT-Fields were continued even after chemotherapy ended until disease progression. Now, the primary endpoint for this study was overall survival, but there were a number of key secondary endpoints as well that I think are important to highlight, including overall response rate, progression-free survival, and safety. So with regards to the patient characteristics, the median age was 67, and about 84% of the patients were male, which is consistent with what we see in other mesothelioma studies. More than half of the patients had an ECOG performance status of 0, and we'll talk about the importance of that later. And 2/3 of the patients had epithelioid histology. Now, the median number of TT-Field cycles in this study were 8. Again, this was considered just like with chemotherapy. Every cycle was 21 days. And the median number of chemotherapy cycles was 6. And about 2/3 of the patients actually received carboplatin. Now, the median overall survival in this study it was 18.2 months. Again, this is the primary endpoint for this study. Also, the 1-year overall survival was 62%, and the 2-year survival was 42%. Now, historically, we have better outcomes with patients who have epithelioid mesothelioma versus non-epithelioid mesothelioma, and this is what we also saw in this study as well. The median survival for those patients who had epithelioid mesothelioma was 21.2 months compared to 12.1 months for those who had non-epithelioid mesothelioma. The median progression-free survival was 7.6 months, and the partial response rate was 40%, and the disease control rate, something that we'll come back to later, was 97%. So therefore, in conclusion, the threshold for significant extension in overall survival, again, compared to a historical control, as this was a single-arm phase 2 trial, was met. The hazard ratio is 0.66. Now, if we put this in light of the other pivotal mesothelioma studies that have been performed historically or even more recently, they're important to think about the epithelioid histology component as that may drive the survival. In this study, it was 66%, two-thirds of patients, which is actually lower than what we saw in, for example, the MAP study or even the LUM-MESO study, which is more recently performed, in which 100% of those patients had epithelioid histology. Yet, if you look at the median overall survival for this patient population, it's very favorable compared to these other historical series or even modern series at 18.2 months. So back to this patient example, again, medically inoperable, unresectable, epithelioid histology. We had the approval at that time, again, 2 years ago now. And so he was actually treated with concurrent carboplatin, Pametrexa, and started TT Fields. Now, he did start off at about a 57% compliance. He did have this grade 2 skin blisters. And as Dr. Sulman mentioned, we used topical corticosteroid creams for this patient to help improve that. The difference is that patients do receive pretty intense chemotherapy, and so after 2 cycles of chemotherapy, he had significant fatigue, cytopenias, again, not unexpected given his age, and a decline in his performance status. We saw a similar decline in his compliance with his TT Fields, down to 32%. He did have skin irritation. Again, this was managed with corticosteroid creams. He expressed his preference to continue wearing the device. And then he was able to complete his 4 cycles of chemotherapy, and then his compliance actually went up afterwards as he didn't have the toxicities from the chemotherapy. And this is his pre-treatment images compared to his post-treatment images, and actually still remains controlled to this day. As you can see here, comparative on that CAT scan, you see reduction in that bulky component, especially in the posterior and anterior aspects of that pleural thickening. And then lower down in the lung, you see reduction in that nodular component as well, consistent with a partial response to his treatment. Now, I did want to touch on the radiologic response patterns Fuller-Seller study, in that 72 patients in this trial had at least 1 follow-up CT scan performed to determine this endpoint of radiologic response rate. Now, the partial response was 40% in those that were evaluable. More importantly, the clinical benefit rate, partial response, and stable disease, this is something that medical oncology trials typically report out. This was actually 97%, so this is actually much higher than what we see with the traditional systemic therapy alone studies. Also, the median time between the start of treatment and partial response was actually 1.8 months. Again, not a cross-comparison across trials, but if you look at, for example, the recent CheckMate results with immunotherapy or even with standard chemotherapy, this is typically prolonged, at least 2 to 3 months afterwards. Now, all patients who presented with a partial response also had continuous reduction in the total sum of the diameters of their tumors, and the median response duration was 5.7 months. So the response rates are similar to those that are reported for the current standard of care therapies, whether they are chemotherapy and bevacizumab, or even now immunotherapies. But they do last longer with the addition of TT Fields. So this led to the FDA approval as a humanitarian use device under the humanitarian device exemption pathway for this, and we've been using this in our facility since 2019. We also have a registry for these patients. There are a number of caveats that have come up over time and discussions about alternative treatment options. I think these are important to note, given that this is a phase 2 study. The first is, for example, the performance status in the enrolled patients. Again, more than half of the patients had an ECOG of 0. This is higher than what we see in other trials. The second is that there are a subset of patients that may respond very well to TT fields, and there are other subsets that may not respond. We don't have markers of disease response, for example, PD-L1 status with immunotherapy, but I think we did see a significant benefit in the epithelioid patients, and that is actually very favorable even compared to the immunotherapy data that has been recently published from the Checkmate trial. The progression-free survival was less than 8 months, and the response rate was 40%. And since the overall survival rate was 18 months, there's always a question of salvage therapies in this patient population. But again, even with the most recent studies that have been published, there really hasn't been a difference in salvage therapies across different arms. There really aren't any effective salvage therapies as well. This was a single-arm phase 2 study, so there's obviously a difference in this approval. This is not the level 1 evidence that Dr. Sulman presented for glioblastoma, and we don't know the optimal duration and compliance. The compliance was a little bit lower on the STELLAR study compared to what we've seen with the glioblastoma trials, and at least in our clinical experience, it has been a little bit lower than what we'd experienced for our GBM patients. Finally, cost is something that always comes to light, but this is not unique to this therapy, as we have novel therapies that also have significant high burden of cost. So this is actually provided in your practice aid supplement or even online, but hopefully kind of summarizes the current evidence and management approaches for malignant pleural mesothelioma. Initially, actually since 2004, we really had no additional treatment options for this patient population. If you go to the very right, in 2019, the FDA approved TT fields in combination with Pametrexa and chemotherapy for patients who met the indication, which was unresectable, locally advanced, or metastatic disease in the first-line setting. Most recently, last year, just about this time of the year, there was a presentation at the IASLC for nivolumab and ipilimumab for this patient population that then led to its approval. I just pulled here some of the data that has come out from the Lancet publication, that there's clearly a benefit in patients who have non-epithelioid histology. The difference in survival was 18.1 months versus 8.8 months. This was a phase 3 randomized trial. So I think that this is clearly the way to go for this patient population. But for example, for epithelioid patients, for those patients who had a PD-L1 of less than 1%, or even for the patients who were elderly, we didn't see that stark or significant benefit in overall survival in that subgroup analysis. So moving back to our polling question number 3, how would you now treat an 84-year-old male with newly diagnosed medically inoperable, unresectable, malignant pleural mesothelioma, assuming he has epithelioid histology and a good performance status? You have 7 options here. Okay, so we made a significant progress here in option number 6. It may be unfair because I actually gave you the patient example and his eventual outcome in this particular circumstance, but Pametrexa, carboplatin, and concurrent TT fields therapy, we now have 83%. So for the second half of this thoracic talk, I'm actually just going to shift the framework to talk about the use of TT fields for patients with lung cancer. I think this is an emerging indication for our patients. So again, second-line options following platinum failure are pretty limited for patients with non-small cell lung cancer. Typically, the course is they're diagnosed with metastatic disease. This, again, outside of the oligometastatic space that we typically work in. They receive systemic therapy. They have a response evaluation. At some point, they will have disease progression. And for patients who have a good performance status at the time of disease progression, there are 2 options, essentially, to consider immunotherapy, and it could be dealer's choice of nivolumab, pembrolizumab, or atezolizumab. All have Category 1 recommendations now. Or to consider chemotherapy, which is typically done in patients who had failed previous immunotherapy, and that could include docetaxel, Pametrexa, gemcitabine, or even docetaxel ramucirumab. So really, following platinum failure, immunotherapy or single-agent cytotoxic chemotherapy are both second-line options. This is the phase 3 LUNAR trial, which is an ongoing study of TT fields with standard of care chemotherapy for patients who have significant pulmonary disease. This is a study of, initially was going to accrue 534 patients who had progressed on or after platinum-based therapy, and then randomized in a 1-to-1 ratio to TT fields and either that immune checkpoint inhibitor therapy or docetaxel. This is at the choice or discretion of the treating team. Or that systemic therapy alone, and they get a CT scan every 6 weeks until they have progressive disease. This is a phase 3 randomized trial. Again, so the level of evidence that will come out of this. And the primary endpoint is overall survival. There are a number of secondary endpoints as well, including progression-free survival and overall radiologic response rate. As said, initially this trial was going to accrue 534 patients. It has been accruing, and actually we underwent interim analysis, which was a routine in February of this year. In April of this year, the DMC, Data Monitoring Committee, actually recommended a reduced sample size of now 276 patients versus 534 patients, and with only 12 months of follow-up, which earlier needed 18 months of follow-up, as it believed that it would provide sufficient overall power for both the primary and the secondary endpoints. So again, this study is accruing right now. We don't have the final outcome, but hopefully we'll be closing soon. There is some data, though, of the use of TT fields in the recurrent non-small cell lung cancer space. So here is a single-arm pilot study, a phase 1/2 trial in 42 patients who had inoperable stage 3B or stage 4 non-small cell lung cancer who had tumor progression after at least one line of prior chemotherapy. And these patients received Pametrexa every 3 weeks with continuous TT fields at 150 kilohertz of at least 12 hours a day applied to the chest and the upper abdomen until disease progression. As you can see here, again, this is compared to a historical cohort, the Pametrexa versus docetaxel second-line study in lung cancer. The median progression-free survival in this study was 28 weeks versus our historical control of 12 weeks, and the median survival was 13.8 months versus 8.2 months, which is, again, our historical control. And so there is some evidence that we at least have of the use and efficacy in this patient population. Now, combining the results from that study, the preclinical or in vitro data from the use of immunotherapy and TT fields, as Dr. Sulman had alluded to, and potentially moving this to the first-line setting, this is a new trial that was recently developed, the phase 2 Keynote B36 trial, which is evaluating the use of tumor treating fields therapy and pembrolizumab in the first-line setting now. This trial will accrue 66 patients with unresectable stage 3 and stage 4 non-small cell lung cancer that have a PD-L1 positivity of at least 1%. Patients receive TT fields and up to 18 hours a day and pembrolizumab every 3 weeks. The primary endpoint for this study is overall response rate. And there are a number of secondary endpoints as well, including overall survival, progression-free survival, 1-year survival rate, and duration of response. So this is a complicated space. There are a number of novel multimodalities that are being offered and being discovered, at least in lung cancer, but this is at least emerging, and the evidence to date has been very favorable. Now, as Dr. Sulman mentioned, we have to integrate this as a fourth type of treatment approach outside of the radiation therapy, systemic therapy, and surgery that we traditionally talk to patients about. For this particular device, at least that we have learned, both in the patients that we've treated on our registry with mesothelioma, as well as put on the research setting on the LUNAR study, and then for the newly opened B36 trial, which we're opening, patient education is critical to this actual device. It's actually the very few patient population that we actually allowed to have as visitors during this COVID era at our facility, and that we had patients and their families actually come together for these visits. We would teach them about the device. Patient compliance with wearing the device is really key, so I show all of the patients the video about how the technology works. We actually have the device in the room with the patient if we are going to be discussing either the study or the registry, and then continuous monitoring is needed. It is beneficial to actually review the device support specialist feedback about the patient, to review the reports with the patients in clinic so you can identify potential challenges that they're having, whether they're taking breaks during a certain period of times. And it's something that you can actually monitor in pseudo real time with your monthly reports. So you can have those discussions with patients to ensure that they remain compliant with the device.
Excellent. I want to remind everyone again, please fill out your question cards. They're going to be continuously collected. And also to please ask your questions online. We are collecting those as well and transcribing those for the group, for this panel to answer. Well, let's move on now, after that really excellent presentation, now to Dr. Horne, who is from the Division of Radiation Oncology at Allegheny Health Network in Pittsburgh. So thank you, Dr. Horne.
Thank you, Dr. Sulman. So I get the most fun part of this talk, where I get to talk about a lot of things that are in the pipeline and the ways in which we can combine tumor treating fields with other modalities of therapy, namely radiation for one, that we are already using to fight cancers that have been proven to be difficult to get rid of. Cancer-related mortality rates in solid malignancies still remain difficult to move the needle on. We have a number of traditional therapies, systemic therapy, chemotherapy, immunotherapy, radiation, sometimes surgery, even in the metastatic setting, that all have associated adverse effects and impact quality of life. And so we need to find better ways of combining novel treatment strategies, such as CT fields, with the weapons that we already have to move that needle without adversely impacting quality of life. I'm going to start off by talking about pancreatic cancer. Preclinical data indicates that the combination of tumor-treating fields and gemcitabine gave a high level of tumor reduction in cell cultures, and that a frequency of 150 kilohertz was the optimal frequency, as we've seen in other disease sites, for reducing the proliferative potential of those cancer cell lines. Similar to the thoracic arrays, it uses 4 transducer arrays that are this time placed across the abdomen, across the front, the sides, and the back, to deliver the tumor treating fields effect to the pancreatic tumors. And there is data from the PANOVA trial, which enrolled 40 patients and combined gemcitabine and tumor treating fields in locally advanced pancreatic cancer that was not amenable to surgery, and found that progression-free survival was almost 8.5 months, and overall survival was nearly 15 months. There was also a cohort of patients that were treated with gemcitabine and Abraxane in combination with tumor treating fields. Those patients enjoyed an even better progression-free survival, and median overall survival was not reached in that cohort of patients. And you can see the progression-free survival curves and overall survival curves there at the bottom on the left and right, respectively. And you can see, of course, as it would follow, that locally advanced patients had much better outcomes than those with metastatic disease, as the disease outside of the tumor treating fields would not be addressed by that therapy and would only be reached by chemotherapy. In comparison with standard therapy for pancreatic cancer, we can see that the historical data for gemcitabine and Abraxane, median progression-free survival is only about 5.5 months. Median overall survival was 8.5 months, not yet reached with the addition of tumor treating fields, and that landmark 1-year survival is more than doubled at 72%. Partial response rates are in the 40% range versus only about 1 in 4 responding with chemotherapy, and the clinical benefit rate, that disease control rate of stable disease and partial response rate, is close to 90%, whereas it's only 1 in 2 with standard chemotherapy. So this indicates that the addition of tumor treating fields really is a separate, independent mechanism of action that is driving tumor cell kill. That led to the phase 3 randomized PANOVA-3 trial, which is currently ongoing. And it is taking that single arm of tumor treating fields with Abraxane and gemcitabine and randomizing it against systemic therapy alone. Patients are being followed every 4 weeks in the clinic with CT scans every 2 months, and they're followed until local progression. The primary endpoint of that study is overall survival, and again, a number of important secondary endpoints, including progression-free survival. Local progression-free survival is, again, the tumor treating fields are only effective at the pancreatic tumor site, and if there are disease sites outside of there, they would not be impacted. Overall response rates, landmark 1-year survival, and of course quality of life, and pain-free survival, which I think is a very interesting endpoint for this particular study. And there are also some other additional endpoints, including resectability rate, to see if some of these patients are converted from being inoperable to being potentially operable. There are, as with the non-small cell lung cancer space, a myriad of studies ongoing in locally advanced pancreatic cancer, looking at adding intra-arterial chemotherapy, the nanoknife, modified chemotherapy regimens, and nanoparticulates, all of which are very exciting and potentially could help, again, move that needle in a very difficult to manage disease. Moving slightly across the abdomen, we'll talk about hepatocellular carcinomas and gastric cancers. Novocure ran the phase 2 HEPANOVA trial in advanced hepatocellular carcinomas using TT fields again at the 150 kilohertz range, concurrent with first-line sorafenib for advanced and unresectable HCC patients. There was 25 patients enrolled on that study, and they were treated with daily sorafenib and the tumor treating fields and imaged every 3 months until disease progression. You can see the schematic of how the arrays were placed. They had 2 arrays on the flanks, 1 anterior and 1 posterior. There we go. And the phase 2 HEPANOVA study ended up enrolling 27 patients. You can see that the Child-Turcotte-Pugh stage was fairly severe in the enrolled patients. The median duration of therapy was only 9 weeks. It was relatively short. But what we did see is that disease control rate was obtained in 3/4 of patients. The overall response rate was only 10% in the overall population. If they were able to be treated for more than 12 weeks, which was 11 patients, so roughly half, the disease control rate went up to 90%, and the overall response rate was doubled at 18%. In comparison to historical control, these numbers are favorable. And this has led to a phase 3 randomized trial, changing the backbone for comparison with the new standard of care, which is atezolizumab and bevacizumab instead of sorafenib, as that is no longer the standard when the phase 2 study was designed. And it has been granted FDA breakthrough designation in HCC. There's also an abstract presented earlier today demonstrating that the maximal efficacy of TT fields in hepatocellular carcinoma is also achieved at that 150 kilohertz threshold. In gastric cancer, we also have phase 2 data that is ongoing. Patients who are being treated with the tumor treating fields and concurrent Xelox chemotherapy, who are being imaged every 3 weeks, being treated every 3 weeks and imaged every 3 months until progression. It's again going to be a small study and designed to determine the overall response rates of that combination, as there is preclinical data, again, that the combination of TT fields and FOLFOX had a higher level of cell kill than either treatment alone. So again, suggesting that there is a synergistic effect here. So we have a follow-up poll question here to reassess your knowledge of current early phase evidence in the use of tumor treating fields in patients with GI cancers. So there are 6 options, 5 of which are therapeutic interventions and 1 non-applicable. All right, so at the pretest, almost everyone said that they were either unsure, had limited knowledge, and at this point it seems that the grasp of the data has improved, so that's good. That means we're doing our job up here. So now we're going to move into the pelvis, tumor treating fields for therapy in ovarian cancer. There's also phase 2 data in the platinum-resistant ovarian cancer setting, which is something that radiation oncologists traditionally are excluded from, except for perhaps in some palliative instances. We don't get to participate in the care of these patients terribly often. But in this setting, tumor treating fields tuned to a frequency of 200 kilohertz, so slightly different from most of the settings that we've been talking about, were demonstrated to have an anti-proliferative effect in cell lines, and it led to the phase 2 study of examining TT fields with weekly paclitaxel in women with platinum-resistant ovarian cancer. Most were serous type, and the median number of prior treatment lines was 4, so these are very heavily treated women. And you can see here that the median progression-free survival was about 9 months, and in comparison with historical control of paclitaxel by itself, that is more than doubling of progression-free survival. Overall survival was not reached at the median time point, whereas with paclitaxel, that's typically just over a year. And the landmark 1-year survival with TT fields and paclitaxel was almost 2/3 of women. Disease control rate was 71%, and only one patient had to discontinue the use of TT fields due to dermatitis. That, of course, led to the phase 3 Innovate-3 trial, looking again at women with platinum-resistant ovarian cancer, taking that same combination of therapy, TT fields with weekly Taxol, and comparing it to weekly Taxol by itself. These women are scanned every 8 weeks until progression of disease. Primary endpoint is overall survival, and secondary endpoints include progression-free and overall response rates. This is going to be a fairly large study and is currently accruing. It's also a very busy space. There are a lot of ongoing studies in the platinum-refractory ovarian space, looking at checkpoint inhibitors, possibly combined with radiation, engineered T-cell therapy, SBRT, TACE in the hepatocellular arena, different immunotherapies, and for biliary tract cancers, looking at immunotherapy, checkpoint inhibitors, and radiation. So there's a lot of exciting work being done in all of these spaces right now. Another follow-up polling question. How likely are you to consider referring eligible patients with GI, thoracic, or gynecologic cancers to clinical trials testing multimodal treatment options such as tumor treating fields? Great. So at the pretest, a decent proportion were unlikely, unsure, or only somewhat likely, and now it seems that the needle has been moved, and there is decent interest in having patients at least be evaluated for clinical trial with TT fields, so that's pretty exciting. So there are some future directions where I think this multimodal approach, the fourth treatment modality, as it were, I think really can have a great deal of promise. Tumor treating fields and radiation have complementary, non-overlapping mechanisms of action, as was pointed out earlier, radiation being ionizing radiation and tumor treating fields being non-ionizing radiation. We've noted in preclinical studies that DNA damage repair is delayed after delivery of radiation and use of concurrent tumor treating fields. Tumor treating fields can actually interfere with repair of double-strand DNA breaks and increase the expression of gamma H2AX, also a marker of double-strand DNA breaks. And so you can theoretically increase cell kill by combining these two modalities vis-a-vis the Trident trial, which is currently ongoing. And there's a potential to really harness these two separate mechanisms of action for a super additive effect of cell kill, wherein you can destroy more cancer cells combined rather than the number of cells killed with each modality individually. Mouse models do suggest that tumor treating fields are immunostimulatory, and so there may be greater potential for harnessing the power of checkpoint inhibitors, for instance, PD-1, PD-L1 inhibitors with tumor treating fields. There may be some upregulation of those markers in tumor cells that, again, produces a super additive effect of the modalities when combined, as opposed to when they're used individually. There's also some early preclinical data that tumor treating fields induce a state of BRCA-ness in tumor cells. And so women with BRCA mutations are eligible for treatment with PARP inhibitors, and those have demonstrated by themselves excellent response rates for those patients. And if tumor treating fields can induce this BRCA-ness state, sort of like HRD, we may be able to make available another option for these patients by inducing a BRCA-ness state and treating them with a PARP inhibitor, perhaps. They may also be more susceptible to radiation in that state. So I think there's a lot of interesting research to be done in that arena, and a number of interesting clinical trials that could be put forth in the coming years. So we need to prepare for the future. There's a great deal of importance on the multidisciplinary and multimodal care of all patients with cancer, but especially in these patients with difficult to treat metastatic or locally advanced disease. Novel techniques, including tumor treating fields and combined modality treatments, may improve the ability to control tumors for longer without impacting quality of life. And there are a number of confirmatory prospective trials underway that will shed light on which options we have beyond chemotherapy, TKIs, immunotherapy, and other treatment strategies. So there is hope. So we've got one reflection question. Do you want to read this one?
Sure. Okay, this is sort of a big picture question for everyone. What did you learn during tonight's program, and what left the biggest impression on you? I'm going to read these. So number one, TT field therapy is an important treatment option to recommend in addition to standard of care to appropriate patients with GBM or mesothelioma. 2, survival benefit with TT fields therapy is directly related to dose density, power density, and field intensity, and patient compliance, device worn more than 18 hours per day. Number 3, managing dermatologic AEs, e.g. prescribing corticosteroids, repositioning transducer arrays that may arise from TT fields therapy can improve compliance. Number 4, novel multimodal strategies are demonstrating promising results in early phase studies and are being investigated in phase 3 trials for lung, GI, and gynecologic cancers. Number 5, all of the above. That's always a good one. Number 6, please don't use. Okay. Well, that's fantastic. All of the above wins. And there was number 2 answer was the use of multimodal strategies, which I think is great. Excellent. So we have an opportunity now to go through the really outstanding questions that have been provided. And I'm going to, since a lot of these and understandably involve glioblastoma, I'm going to kind of share the wealth a little bit with my colleagues because they have experience beyond that, beyond just the areas they've covered. I'll answer a few of these relatively quickly. Someone asked about the Trident trial, whether it would be, whether it's blinded or whether there's a sham tumor treating field device. And there is not. Just like the EF14 trial and the EF11 trial, there's no sham device, and I would just say that there's been a lot of discussion over the years whether a sham device means anything, whether there's a placebo effect, and the data really does not support a placebo effect having a survival impact in a clinical trial. And then the same person asked if tumor treating fields is effective in disrupting mitoses. Why do we only see a few months OS improvement? Again, that's median overall survival improvement. But we see a near doubling in survival percentages at 2, 3, 4, and 5 years. And the mechanisms of resistance are asked about, and that's an active area of investigation and may overlap somewhat with some of the resistance we see with ionizing radiation. Why don't you take one? We'll mix it up a little.
This question is for PANOVA-3, the locally advanced pancreatic cancer study. Can patients receive pancreatic-directed radiation at some point in therapy? The study excludes radiation while on therapy, but then, of course, after the patients progress, they can be treated with radiation.
Fantastic. I'm going to hand you that. Okay. Sorry, we got to divvy up here a little bit. I'm going to hand you that. Okay, I'll get through a couple of these I can get through quickly. Somebody asked if tumor treating fields are appropriate for lower grade gliomas. We simply don't know. We don't have the clinical evidence yet to support that. And those trials, as you may know, whoever asked this, are quite difficult because they already have a fairly long survival. And so it's, as I always say, if you do research in low-grade gliomas, your children and grandchildren will be reporting the results. So no, you can take that one if you want, or you want to ask one of yours?
Sure.
Yeah.
So I can start with two here. So the first one is a radiation oncologist who's trained in TT fields for GBM, but how do they transition to the use in other disease sites, for example, mesothelioma? So you just have to look at the approval process for these different indications. For example, for mesothelioma, that was approved under the humanitarian, as a humanitarian use device under the humanitarian device exemption pathway. What that means is that in addition to the training on the device, which the company will provide you, and if you're already used to it, a lot of the principles are the same, you just also need to have either a local committee or an IRB approved indication for use. Now that can be done at your own institution. For example, when we started that back in 2019, we went through our own institution and have renewed a registry. But most of the institutions now are just using a third-party IRB. It's very easy to set up, and at the time of your training, the company can actually take care of a lot of that submission for you and your hospital system. The second question, I think, was the role of radiation therapy in the STELLAR trial, and I'll probably use that as to how do we use it in clinical practice. So this was not used in the STELLAR study. Those patients actually just started their treatment with chemotherapy and TT fields therapy. But I think in clinical practice, it's very common that the patients have some degree of symptoms related to their chest wall disease. The way that we approach all these patients at our facility is that we see them on the first day, we simulate them, and then essentially at that time, we'll actually put in for the approval for their TT fields for their treatment. All of our patients are treated to 40 gray and 10 fractions, a very common mesothelioma palliative regimen given the radioresistance of that disease. And essentially, they'll finish their treatment, and as soon as they're done, they'll start their chemotherapy and their TT fields treatment. And that actually window works out well for how long it takes to get the device approved and then do their teaching. Although we haven't seen yet the results from these ongoing studies in the brain, we do reduce the dose to the skin or use any specific planning constraints given some of these skin disease or could be superficial disease.
I'm going to just go through a couple of quick ones here. Do we go beyond 24 months since the trial stopped at 24 months for glioblastoma? I do go beyond 24 months if the patient is willing. Especially if they haven't progressed or maybe they only had one progression. Like many trials, you have to have a fixed treatment endpoint, and 24 months was chosen, but that doesn't mean it stops working at that arbitrary time. Is Optune tumor treating fields shown to be useful in molecular glioblastoma? Undoubtedly, there were probably some in there, but of course the trials used a histologic diagnosis of glioblastoma. So I can't definitively say that that's true, and I think the WHO guidelines that are coming out in 2021, which really re-engineer a lot of the brain tumor classification, are going to complicate our interpretation of clinical trials across the board, well beyond the field of tumor treating fields, and that is just one example. Here, I'll hand that to you. We'll let you do a few questions.
So there's one, any role for liver metastases in future trials? I think that's a very interesting question. There are no current studies undergoing. There may be some issues with tuning the fields in that kind of study because they would be of a variety of histologies, but certainly that might be a very reasonable space to explore, especially now in light of the HEPANOVA study launching. We'll have good safety data, at least from that standpoint. I have another series of questions. What are my thoughts, and you can both chime in on this, on who should be prescribing tumor treating fields? I think that really depends on the disease site. I think it makes sense for radiation oncologists to help manage glioblastoma patients, non-small cell lung cancer patients, because we have a large stake in their care. There are other patients like the platinum refractory ovarian cancer patients who we would be entering a new arena and may not be familiar with all of the aspects of their care, and so GYN oncologists tend to manage that. So I think it does vary. Who should be dosing and monitoring the TTF? The dosing is standard. That's set based on the clinical trial. But in terms of monitoring, I think the onus falls upon the prescriber of the TT fields to make sure that those patients are coming in for the routine imaging, routine clinical assessment, managing their skin, and by an extension, having your staff trained for the implementation and management, knowing the questions to ask, and Novocure is very helpful in educating your staff on how to manage the device, asking the appropriate questions about skin toxicity, what are patients doing in terms of their array changing routines, et cetera. So the company is a very good resource for that.
I'll give you some.
Sure. So I have a question here about GBM, and I'll also probably answer it for mesothelioma, but on the compliance rates for patients wearing the device on their head. So at least in the EF14 trial, the compliance rate for at least 18 hours a day was about 75%, and so that's been used in other studies as well. In the Stellar study, it was actually down to 68%, so 16, I think, 0.3 hours, so a little bit less than the 18 hours a day. But you do self-select out the patients who are interested in the device. I think it's not a large uptick at the very beginning for the patients, though, who ask to wear the device or who are seeking it, or when we discuss it with patients in the clinic who are interested in it. I mean, those are patients that are self-selecting themselves to probably be more compliant with it. You just have to manage the skin-related toxicities associated with it.
I would just add that it's important not to make any assumptions about a patient and their willingness to use the device. Really, certainly for glioblastoma, this is standard of care, should be offered to all patients. Some say, well, women will never use it because they don't want to shave their head. I actually have more women than men that use it. So when it comes to really wanting to improve survival, I think hair is often a secondary consideration for most people. But in general, it's really important to objectively present the information and the data just as you would temozolomide or the use of radiation itself. Someone asked for whether we should be using the preoperative T2, or I guess FLAIR MRI for TT field planning. This hasn't been done. I think the key reason is just because of the changes induced by radiation and the time period between a preoperative study and the end of radiation when you'd be giving adjuvant therapy is several months. So I think the tumor has really evolved at that point, and the imaging is really very complex. This was a really interesting question. Because of the orthogonal placement of the fields, somebody asked if we should use, actually left their name, thank you, Dr. Berkowitz, we should be using a rotating field to give better results. Fascinating idea, one that we should probably discuss with Novocure. But I could conceive doing it, simply alternating which array in a circular motion is getting it. Would need some preclinical studies. Did I leave you with some more?
I have a couple, yeah. These are all sort of related to immunotherapy. One, did TT field sensitize patients for PD-L1 or PD-1 inhibitors or vice versa? That we don't have an answer to from preclinical data. And then there's two questions sort of similar about the mechanistic rationale for combining TT fields and immunotherapy. There's preclinical data that TT fields upregulate PD-L1 expression and therefore might make patients more susceptible to that kind of therapy.
Okay, I think we are actually out of time, but I want to thank my colleagues up here on the podium for their outstanding talks. I want to thank all of you in person and remotely for attending, and of course thank PeerView for putting on this symposium. Thank you.